Um, all right, I'm really excited to present about our presenter today, Brooke Pohlman. Brooke is an occupational therapist with over 21 years of experience in neurologic rehabilitation. She has practiced in acute inpatient rehabilitation, specializing in spinal cord injury, stroke, traumatic brain injury, and community reintegration. And currently, Brooke is practicing at the Sugar House Rehabilitation Center, where she is the driving rehabilitation specialist. And as a certified driving rehabilitation specialist, Brooke, she conducts evaluations that are designed to assess clients who wish to return to driving following an injury or accident, as well as older drivers who are wishing to continue to drive. Um, Brooke is also an adjunct faculty member in the Occupational Therapy Division at the University of Utah. And we are so excited to learn from her today. We also have, um, at the end, we'll also get to hear briefly from Megan Smith from the Adult Protective Services and Jamie Troyer with the University of Utah's Trauma Injury Prevention Program. So, with that, I will turn the time over to Brooke.
Thank you, and thanks for having me. I'm excited to be here, excited to hear about this program. I think it's so important and well needed throughout the state. So I'm excited to share maybe what sort of my area of expertise, which is driving. So I think to just start off, I think talking about what we probably already know, that driving is such a hot button issue. That's maybe why a lot of you are here, because a lot of you get lots of questions or concerns about our older adults and driving. And it's one of those situations where, of course, we want to balance safety being number one and somebody's independence, and there's a lot to be said about that, about that balance, and a lot to be said about not removing driving privileges too early, and of course, not too late. And so, trying to find that fine line. I think that opening up a conversation about driving, although it is so difficult to talk about driving. I mean, I think most of us know that even in our own personal relationships, maybe with a partner or spouse, talking about each other's driving skills doesn't always lead to the best of feelings. But I think, especially when we're dealing with our adults with cognitive disorders, that we need to start the conversation early. I think early conversations and early planning around driving, obviously, we get a better outcome. And so I think sometimes when I'm assessing patients, a lot of times things go better if we kind of have a plan. And I think that, and if we kind of have an agreement, and if we kind of open it up early on. A lot of times, I think one of the things is family members really do have their finger on the pulse, or they hopefully do. And so, family members or supports a person's support system sometimes are the best in the best position. They can see the waxing and waning of a patient day to day. When I'm assessing a patient, unfortunately, it's a snapshot. It could be a person's good day, or it could be their worst day, and so that can be difficult. I think having an idea of kind of a patient's or a client's like days and routines and that sort of thing is very, very helpful. A lot of family members that I work with are, saying, well, I don't really know how my loved one's driving is. I haven't ridden along with them. I haven't been in a car with them. And that's really difficult. And I also understand why somebody might not want to ride along with someone. But I think we're going to talk a little bit about what you can glean from doing a ride along with somebody. I think, too, a lot of times we have to remember that older adults are typically participating in less risky driving behaviors in the way that, if you think about a 16 or 17-year-old who maybe is a new driver and is somewhat invincible in their own mind. I think remembering that most of our older drivers are driving shorter distances, they're driving during daytime hours, they're driving familiar places, and they're not always driving at high speeds, kind of anything over 45 miles an hour. A lot of them are already just saying, well, I want to stay off the interstate, or I don't go this place or that place because I don't feel comfortable. So some of them have already self-restricted their driving, which is oftentimes a good thing, a really good thing. So I feel like, knowing those habits and routines and kind of what a person is doing to start with from a family member standpoint can be really helpful. When I think about drivers, and when I'm kind of like categorizing drivers, sometimes I, of course, have the advantage of having a medical record because I work for University of Utah Health. A lot of my clients are referred to me through a physician. And sometimes I get kind of the background, the medical background. So instead of just thinking about kind of normal aging, which, is something to think about too. I think normal aging in combination with medical issues and maybe how complex those issues might be. So I kind of like this infographic that the Occupational Therapy Association put out a while back, just thinking of a driver as kind of the red light, a green light driver, or maybe somebody in the middle, kind of that yellow light person where you're kind of questioning, is this person capable? And how do I know that? What information do I have based on what I know about them? So that can be anything from a family member or caregiver, or the social worker, or whomever is involved with this person. Like I said, I do get a lot of referrals from physicians that are concerned for one reason or another, but certainly a lot of my referrals are from that support team that maybe they've observed something, or they're just not sure, or quite frankly, they don't want to have the conversation with their loved one. That happens a lot too. So, in regards to fitness to drive, I kind of think, if we can think about if you're thinking about a particular patient or a client that you might be seeing, thinking about, where are we as far as, red light, green light, yellow light kind of person? Like, is this person somebody we really need to be concerned about and we don't think they should be driving at all? And hopefully we can have them assessed before that's the case. Another thing I'm going to kind of talk about later on too is just thinking in terms of, sometimes when family members are asking me about driving, I like to think about, or I like to educate them that really there's kind of three categories that kind of make up a person's skills and abilities, and that's their physical abilities. So of course, like their arms and legs and how they're moving, their neck range of motion. Can they feel their feet, or do they have like some sort of neuropathy? Thinking about their vision, do they have vision issues? And that can be a range of things, and not necessarily that we think that family members should know these, all the vision problems, but again, kind of thinking, oh, okay, well, you know we've got a little neuropathy going on, we've got some vision, and now we have this cognitive impairment and this dementia. Those three areas really make up somebody's reaction time. And we're going to talk a little bit about reaction time and what that means, because sometimes I think it's a bit of an umbrella term, and kind of thinking about, well, what does response time or reaction time actually mean when we're driving? But when I talk to families, a lot of times it's obviously here we're talking a lot about cognitive concerns, memory, problem solving, attention, those sorts of issues. But I think sometimes if we have a little bit of language to put around maybe why the person isn't safe to drive, I think it can be helpful. And I find that in my evaluations that if I've kind of put the words to it and the language to it, a lot of times the conversation also goes better. So going back to kind of some warning signs that family members could be looking at, I really love the Hartford Insurance Association had put out a bunch of resources. They have online classes and planning sheets and guides to talk about all sorts of different things with aging adults and even teen drivers. But one thing that I've used for a long time is, I'm just going to click on this link. It's a warning signs checklist. And again, when I'm asking patients, now can you see this screen? I hope. But when I'm asking patients or family members, what is the concern? What have you noticed as you're riding along with a patient or with your loved one? And I kind of like this because it's a list of 30 items that are pretty common to that we commonly would see as warning signs that maybe somebody isn't safe to drive. So you think about so other drivers honking their horn, or maybe the person has difficulty navigating turns or staying in their lane, or not anticipating dangerous situation, or the judgment at left-hand turns is a common one, or maybe we have these near misses, where other drivers are, kind of on the lookout, or at least slowing down for a person or something like that. As a family member is riding along, are they noticing some of these warning signs? I use this checklist all the time to describe to kind of put into language, because I often hear from family members that, well, I don't feel safe with them, or which is valid for sure. But again, kind of putting a little bit more specificity on the situation, I think is helpful for the family, but also just for that client. I think that, the more warning signs we have, the more boxes that have been checked. And obviously, we're all going to make driving mistakes, but are these mistakes happening consistently when a family member is riding along? I think it's a good comprehensive list. Of course, there can be other things. I just wanted to point out number 16 here, where it says use as a co-pilot. I have some, you know, maybe a husband-wife situation you can imagine, and maybe the wife doesn't drive anymore, and the husband's still driving, and the wife says, well, he's doing great and I'm always in the car. But also, is the wife providing co-piloting cueing, meaning she's kind of saying, okay, there's a stop sign coming up, and okay, you can go now, or slow down here, or whatever it is. That's different than somebody navigating to a destination. Co-piloting is more of those safety cues in the vehicle. And I think sometimes people we talk to me about, well, he doesn't go anywhere on his own, I'm always with him. And maybe why is that? Could he do it all on his own? Because of course, if somebody is capable of having a driver's license, they need to be capable of doing all those things all on their own. So anyway, I really like that checklist, and thinking about using the checklist to look for patterns or changes. That this isn't as the typical way this person drove has changed over time. I have a lot of patients that maybe have a little more anxiety around driving, or they're hesitant in making their decisions, and that was never the case before. So I think to avoid, when we're talking about observing these warning signs, avoiding alarming reactions, which that is easier said than done, but avoiding those confrontational situations in the vehicle, maybe kind of saving it for a time where you could talk about it. But that can be a challenge, as we all know as well. I think when it comes to difficult discussions, I mean, I have them all day, every day. They're very, very difficult. And I think, sometimes the family member themselves, that is the caregiver, is not the best person to have the discussion. I think that's oftentimes why people are, paying money to come and see me and have their loved one tested. Sometimes the caregiver might know already that this person shouldn't be driving, but they simply don't want to have the discussion because it can be so difficult. I do think, though, I know that even once I've evaluated somebody, they're going to leave here, and the family carries that weight of actually helping that person maybe retire from driving or whatever it is. And so I think, of course, staying calm is the best thing. One thing that I typically find is, if I can kind of tap into what makes the person tick, so to speak, what is that, the values that the person has, what do they care about? When I'm doing my evaluations, I often kind of pick up on different things, like, well, I used to drive bus for a living and I kept those kids safe, something like that. And then when I'm talking about, well, you're no longer safe to drive, it's time to retire from driving, I would tap back into that. As a bus driver, how important safety is, and you would do anything to keep your passengers safe. And if you weren't capable, if you had an impairment, you would stop driving. You would have stopped driving that bus. Oh, of course I would have. Things like that that can really kind of tap into what that person values when it comes to driving. I've had other patients where they're very concerned about finances, and we talk more about the lens of, if you continue driving and we're in an accident, a lawsuit's very expensive, or an accident's very expensive, much less hurting somebody, and sometimes the money is the motivator. We want to maintain the life that we've had, and everything we've worked for. And so stopping driving is it makes the most sense, or something like that. Like having that conversation that kind of speaks to what that person values in regards to, whether it's safety or maybe money, or maybe, there could be a variety of things. But I think that often helps the conversation and helps the person realize, that this maybe is the right decision to retire from driving. And I continue talking about retiring from driving, because I think that is one of the most difficult conversations that people kind of come across when it comes to driving. I think the other things is, try not to be accusatory when you're in the car, or otherwise, but instead kind of using those I statements of, I didn't feel safe, and I don't want anything to happen to you, and I don't want anyone else to get hurt. Those are helpful. And I think if you've ever tried to have a conversation about somebody retiring from driving, it's really difficult. And all I can say is that every person's a little bit different. I think that also the relationship and the dynamic of the caregivers can be difficult. And so finding the person maybe that person connects with the most, or trusts the most, and having them have the conversation. And also I think just easing the person from being a driver to a passenger, kind of easing them into riding along as a passenger more and more often, as this person is going maybe through the progression of their cognitive impairment. I will say, I just wanted to bring this up, that once we get to a certain place with dementia where lack of insight is the most prominent. And I think these are the people we hear about the most, the people that have no clue that they shouldn't be driving, and they don't understand why they shouldn't be driving. They think they're perfectly capable. They're not aware of their deficits at all, or their impairments. I'm going to be honest, it's the hardest case. But I think remembering, as a specialist with dementia, that not every patient is like that. I mean, I would say in my clientele, that's probably, I don't know, 7-8% of the people that I see, not very often. But I do think it's a big problem, because I don't know, after all these years of doing what I do, I can't say that I know of something specific that helps with lack of insight. I mean, I've tried all the tricks of videoing the person, or, trying to help them understand best I can. But at the end of the day, when we're at a certain place where a person has very little safety awareness, it is going to be very, very difficult to help that person understand why they can't be driving. Keeping in mind that that doesn't happen with every patient. A lot of my patients are very understanding. A lot of them will say, well, now that I've seen how slow I am, or now that I've seen, that I'm a danger, I don't want to drive. A lot of my patients are like that. So understanding that that can happen too. Again, I think we hear the horror stories, of course, and find those cases the most challenging, because they are. And I wouldn't say that I have any magic solution to having those conversations with a person with such poor insight. Those are definitely the hardest cases. But I do feel like it's a small majority in a lot of ways. And again, if we can kind of have started the conversation earlier, in maybe the dementia process, that can be helpful. And just know that you're not alone with somebody that has lack of insight. I mean, you kind of have to throw everything at it, and kind of work with who you have and what you have, I think, in that moment, in that day sometimes. Um, speaking of driving retirement, one thing I often tell folks when I'm evaluating people is, when we have to have this conversation of driving retirement, there are pretty simple ways that we can remove somebody's driver's license. And the license itself can be revoked or removed for a medical reason. Certainly, something like dementia falls in that category. We can work with a primary care physician or the neurologist, for example, whomever is maybe treating this person for their dementia, if there is a medical personnel involved. So removal of the driver's license is actually, I would say, the easiest part. We notify the driver's license division, they notify the patient and say your license has been revoked for a medical reason. But the hardest part is really kind of when, even after that's done, of course, some people will still want to drive. They'll try to drive even, without having a driver's license. So I often talk to families about the 3 R's in driving retirement. And those are, number one, kind of removing access to the vehicle or to any motorized vehicles. I've had patients that sneak out on the side by side or whatever. So, removing access. And that comes along with a lot of different ups and downs. Some of our patients feel very comforted when the car is in the garage and it's sitting in its usual spot. And some of my patients would never attempt to drive it once they don't have a license. They just want to check and make sure the car is there. Other patients, as we know, would try to drive even without having a driver's license. So removing access to the vehicle. Sometimes it's as simple as taking the keys away. But I'm sure all of you have heard about disabling the battery or taking, steps to make sure the car doesn't function or whatever. Sometimes removing the car completely from the environment is helpful, and it's not a temptation. And it's also, then the car's not there, and all of a sudden the person doesn't think about driving anymore. That happens for some people. For every patient, I would say it's different. But it's very important for someone to remove access to that vehicle. Especially with certain patients that would try to drive if they aren't supposed to, and I do think that's probably one of the hardest things sometimes, and knowing if we remove the vehicle, is it going to agitate the patient or whatever. I mean, those are difficult things that there are a little bit of trial and error sometimes if that's the case. I think the other thing that can be, of course, extremely difficult is replacing the transportation. I mean, this is where of course, around Utah, we don't have great options we have some resources for transportation needs for older adults that aren't driving, but replacing the transportation can be really challenging depending on somebody's support system. I mean, we often tell patients the best thing you can do for your brains is to be social. And now we're not letting them drive and go to wherever it is, to see friends, to see family and whatnot. So replacing the transportation can be very, very difficult. I mean, a lot of people are having their needs met by grocery delivery or Meals on Wheels or medications or something. But if that person is then stuck at home, it's not going to be good for their overall health. We know that. And so trying to find solutions to get the patient out and engaged. I often think of senior centers where they provide transportation to and from, there's Uber Senior, there's GoGo Grandparent, there's lots of resources out there, but still, I mean, the finances for those sorts of things, because these aren't people that can, take a bus necessarily, or that we would want that vulnerable adult on public transportation. And that's usually not obviously is not doable for that person either. So, replacing the transportation can be very, very difficult. And then remembering that driving, a lot of times, it's not about needs. It's really about wants. It's about spontaneity, leisure, freedom. I think that remembering that driving helps a person get out of their house when the days are long, and when they have really limited interaction. We can provide everything in the home if we needed to, the needs would be met, but that's not always what driving is about. And I think remembering that if the more spontaneity, the more wants we can meet for somebody, not just their needs, the more successful driving retirement becomes. So easier said than done, obviously. I just wanted to talk for a minute about what a comprehensive driving evaluation entails. That's what I do. That's what I've been talking about. And just to note that there's lots of driving programs. This is the University of Utah's program. We've had our driving program for about 28 years. I've been running it the past 11 years. Basically, it's sort of an evidence based assessment of somebody's skills and abilities. And there's these kind of two parts, I guess three sort of. There's this clinical assessment that I'll get into, and then there's the behind the wheel assessment where we drive in an actual car. So when I see somebody, it is a 2-hour appointment, and I am doing, my evaluation. It's 2 hours. It's $250. We don't need a doctor's referral. It's not a requirement to have a referral. I often like working with doctors because then I get a full breadth of, kind of the medical background. It's kind of helpful to know that somebody has diabetes along maybe with their dementia or whatever it is. So it's nice to do, but we don't have to do that. I have a lot of patients that are just self-referred from concerned family members or loved ones or whomever. So we don't need a doctor's referral because we're not using a person's insurance. Driving is really a tricky issue because it does oftentimes have a lot to do with somebody's health, but health insurance does not consider driving part of their umbrella. And so we at the university, we've always kept our driving separate because we just can't get it covered through insurance, unfortunately. So it's a $200 kind of a cash fee appointment. And like I said, kind of the three parts, the clinical, the behind the wheel, and then kind of a review and recommendation from me. So going back to, the things we need to watch for and the things I'm assessing for, and my background as an occupational therapist, am pretty well trained in these three areas of physical disabilities, visual disabilities, and then cognitive disabilities. And that again is sort of somebody's reaction time. If I'm seeing a patient that suffered a stroke a few years ago and maybe now has developed a cognitive impairment or dementia, they could have other issues than just something like dementia. And oftentimes our older adults do. Most of our clients do have kind of multifocal aspects of impairment, not just cognition. And so I think making sure that a person, even if somebody just has a hard time turning their neck, as well as has difficulty with processing speed, that right there is another one of those kind of warning signs or triggers for, is this person safe to drive? So the way I assess that is, again, I kind of do a physical assessment. I do some visual assessments and then some cognitive assessments. And leading into reaction time, a lot of people tell me, well, they're slow to react or slow to respond. And I think of that in a couple of different ways, and we assess that in a couple of different ways. This picture here is something called our Dynavision. It's actually the board behind me. This is where a person would stand in front of the board and, kind of hit these red lights that are going on one at a time, kind of in their surroundings. And they don't have to stare straight ahead. They can look around and turn their head and eyes as much as possible. And then we can have numbers lighting up in that blue screen in front of them, and the patient has to push the red buttons around them, kind of working on those visual motor skills. Can the person turn their head and their eyes, but still quickly notice what's right in front of them? Are they fast at doing that? So there's a couple different ways there. We have a touch screen sort of system that's similar, that that has the same functions. And then of course we have a driving simulator, which is also behind me here. And a driving simulator, I have a love-hate with. I think a lot of people feel like it's a video game. It kind of is, honestly. And it feels that way to especially our older adults. It does have a couple of features that I really like, which are, it gives me a reaction time that's very simple, a gas to brake light and timer, very simple. That has research about somebody's, simple visual processing speed and their speed of response, of course. But then we kind of get into more complex situations of problem solving, decision making, and how are we assessing that both in the clinic and on the road? I think that the simulator gives some information, doesn't give the whole picture, which is why I use it to gather data. But sometimes it's not it just isn't the same as on the road. So we can get some data from that, along with the other clinical assessments. I do some other cognitive assessments while we're here in the clinic. But then after that, we typically go out on the road. So obviously, I'm hoping the person has passed the clinical portion of the assessments, and those are things like the reaction time, identification of road signs. I do a couple problem solving activities and things like that are kind of simple. Then ultimately, it leads to the behind the wheel assessment. And that assessment is in the university vehicle. It's this little Toyota RAV4 that you see. It has a passenger braking system in it. So it's sort of like a driver's ed car. Which I'm grateful for that brake often. I use it often, unfortunately. So we go out on a little road test. It's about 30 minutes. And we obviously leave from the Sugar House Clinic. And I take them on a route. We do a couple maneuvers and then, just drive around town. It's very similar to maybe what you do at the driver's license division when you're getting a license. And I'm looking at things like, can they stay in their lane? Are they making safe decisions and judgments and left and right hand turns and lane changes and those sorts of things? And so each person during the behind the wheel evaluation is, starting with 100 points, and I'm deducting points as we go along. Of course, if I'm using my brake on my side, it's an automatic fail. The person has to pass with 80 points. So you can imagine, if you miss a blinker, if there's minor situations, and then of course there's more major problems and issues. So I'm combining that assessment with what I already know in the clinic, what I've gleaned from my clinical assessment, doing the on the road assessment. And then after that, we're kind of having a discussion, and I'm making some recommendations. Just wanted to point out that I'm not the driver's license division. I do not issue a driver's license. I don't take away a driver's license. Oftentimes I'll recommend to the doctor to take away the license. I recommend to the patient, to the family, that this person shouldn't be driving. I don't directly report to the driver's license division. I report back to a person's medical provider if they were referred, or we talk about if the family referred, we talk about the next steps. Sometimes, if the person is newly diagnosed with dementia, obviously we're not always talking about driving retirement. Sometimes we're just talking about restrictions. And oftentimes I'll recommend driving restrictions, and those look like maybe a speed restriction. And that would mean that the patient isn't I'm recommending the patient doesn't go on streets or roads where the speed limit is posted, over 40 or 45 miles an hour. So we're keeping them out of those high speed situations. Sometimes it's an area restriction, driving, 5, 10 miles from their home. So keeping them in familiar places. Sometimes I'm recommending daylight driving only. So no nighttime or dark driving it in darkness. Obviously, I often recommend driving retirement. And then sometimes I recommend that the doctor complete what's called an FAE form, a medical form, indicating that this person is their patient and they're being treated for a disease such as dementia, and that person then would kind of be tracked by their physician, and the physician would then have to sign the form. Sometimes it's every year or every 2 years, or I've had people that have the doctor signs it for 6 months. And so at least it's sort of a check and balance system between, we know that this person has a progressive disease, and we're going to kind of follow up and watch their driving closely. So that's sometimes a recommendation. I just want to point out at the driver's license division that any community, as I'm always surprised that people don't know this, but any community member or concerned citizen can always fill out an unsafe driver form. And it kind of just looks like this. It's anonymous. You can send it in to the driver's license division, and you kind of fill out. You don't have to know their license number, by the way. You can fill out if you have a relationship. So if you're a family member, but you can also do it anonymously and kind of talk about what you noticed, the concern that you have, or whatever the issue is. So that form is available on the driver's license division website. And so, sometimes I've had family members that go ahead and do that. They fill out the form because they have a concern, and that basically initiates a process from the driver's license division themselves, from the state, where that person would have to complete a written skills test, and then a driving skills test. Or and often this is kind of comes in combination, that form, the FAE form, let me go to it really quick, that this form be completed by their doctor. So let's say a family member submits that concerned citizens form to the driver's license division. Oftentimes it comes along with this medical report that this has to be completed by a doctor, stating if the patient has any concerns in any of these areas. So, for example, neurologic or maybe learning and memory concerns with a diagnosis of, let's say, dementia. So a doctor would have to fill that out, indicating that yes, they have this diagnosis, and yes, the doctor feels comfortable with them driving. So that form can be completed. As you can see here, the form 2 with those restrictions, that form can be completed with the restrictions or the recommendations that I make. We can do that on a driver's license, and that goes on the back of somebody's license that says, daylight driving only, or no speeds over 40 miles an hour. That way, if they are on the freeway, and they shouldn't be, if they get caught, they could be ticketed, of course. Again, some drivers have already done this themselves. They don't want to drive on the freeway. They don't want to drive at night, and they aren't doing that, and they've already kind of self-restricted. In those situations, that's okay. We don't have to put it on somebody's license necessarily. But there are situations where that might be helpful, or that might be a deterrent to somebody, maybe. So anyways, that form is what can be done if we wanted to. When I make those recommendations, I meant to say, if I'm making a recommendation about daylight driving, or no driving on the freeway, and I know that my client is either not going to remember those restrictions or not follow through, I have to weigh those options too. I'm thinking about, even if I recommend this, would this patient do it? And sometimes non-compliance can be a problem. And so sometimes we might have to maybe take a harder action, and that might be, then you can't drive at all, and you have that conversation instead. And that happens from time to time. In addition to the medical form, there's also a visual form that can be filled out. So if the issue happens to be something in regards to their vision, like maybe they have a visual field cut and they don't have they don't have enough peripheral vision or something, then we can have an optometrist or ophthalmologist fill out a visual certificate along with other things. So if the issue happens to be more visual based. Um, okay. I just wanted to point out a couple of resources. I just left these links here that I think we can put in the chat as well. But the driver's license division does have some helpful information. And I think, like I said, even that concerned citizen form, if you are in the situation where you're advising a family member or something and they have a lot of concerns, maybe they are not close to a place where that person could be evaluated, filling out a form as a concerned citizen and having them tested at the driver's license division may be the most helpful. Of course, there's a chance that person wouldn't pass that testing and the driver's license would be automatically revoked, which maybe that's the outcome that's safest for everybody. But that is something to think about. I think too, just on the website, on the driver's license division website, there is a medical advisory board at the driver's license division, and they are responsible for kind of making up the impairment ratings and the guidelines to, if somebody has a disability of any sort or an impairment of any sort, when do we need to say no more driving, and what does that look like? So those medical standards are on the website as well. I put here the link to the Hartford Insurance Company, that resource about driving and a lot of different things, but a lot of things about driving and aging and these driving safety guidebooks. I think they're very helpful. They give a lot of language and ideas to patients and family members. So if you want that. And then also I just put the link to the University of Utah to our driving program, what I do, and just my name and contact information there if you need it. So that's all I have, and I'm happy to maybe go to the next person. Oh, Megan, I'm not sure I can hear you, but it could be me.
I'm not hearing you either, Megan. Let's
Oh,
see.
yeah, thanks.
Can you hear me now?
Yes.
Okay, perfect. I always have to remember to switch when I go from different platforms for my audio to work. Hi, everybody. My name is Megan Schmidt. I am the training manager with Adult Protective Services. So I was asked just to join to talk about, because we do actually get a number of kind of cases or concerns that do come into our agency statewide every year regarding concerns with our driving population. And so the big things that we do consider within our agency, because as kind of Brooke has talked about through this time, that is something that we may have to address as we age, especially if there are changes in the cognition for the individual. One of the biggest considerations that our agency is looking at is that capacity to consent and what their understanding is, and that kind of directly correlates into if there is a cognitive impairment and what the progression of that is looking like. So if we would have a case, oftentimes it may be tied to a self-neglect allegation where there's a concern that this person may not be safe to live either on their own or in their current environment. And then there's also concerns with them being behind the wheel or what that looks like. And so we are looking at those aspects. One of the biggest ones that we are looking at, that consideration, is those medical recommendations. Is there a dementia diagnosis? What do we know about that? We do get a lot of concerns that say, my grandma should no longer be driving. Just because they do a lot of the things that Brooke talked about, they don't feel that they are safe behind the wheel, or we'll get calls that will say, I recently visited a loved one and there's a bunch of scratches on the side of their car, so they must have gotten into an accident, but they didn't tell us about it. So there are a lot of things, a lot of ways that can happen. Damage can happen to vehicles, but there also could be those concerns. So those are the things that we're looking at. So if there are anything that can be reported to us, or if we can be aware of, if there is a diagnosis, if there are concerns, The next one, and one of the other ones that we're looking at, is law enforcement involved. So has this person been ticketed? Has there been an accident recently that's happened? That's also really important for us to know as we look at those recommendations. The level of care need is one of the biggest considerations. Brooke hit home on it, because if we are taking something away from their independence or their ability, what we can do to replace that. And so with that, whether it be connecting them with the area agency on aging that could provide medical transportation within the county that they're residing, or if it could help them get to the senior center every single day so they can maintain that socialization. A lot of our older adults oftentimes recognize that they may not themselves feel safe behind the wheel, but they're not sure how to have that conversation. So starting it, and it was mentioned many times, having that conversation early and often. And if you do have a concern for maybe short-term memory loss for an individual, writing it down and then having that often piece of it. Each time that you're communicating with that person, either that family member or that care loved one that you've got, making sure that we've got that information in place and having it consistently talked about. We do get asked a lot. We'll get those calls oftentimes saying, can you take somebody's driver's license away? Or can you help us tow their car away? And different things like that. That is not something that we are able to do within our agency. It's not a role that we would take. We do actually refer a lot of family members to those forms that Brooke had identified in terms of the unsafe driving form and different things. We have actually had neighbors that will just submit the form and then they'll actually call our agency and say, I just submitted this. I do have concerns for my neighbor regarding their driving. But it's knowing kind of what those services that are in place, again, is one of the biggest considerations that we're looking at, because, and how it ties to adult protective services, loneliness, social isolation, inability to connect with others directly correlates with an increased risk of abuse, neglect, and exploitation. So we want to make sure that the individuals, whether due to age-related memory issues or if there is related to a cognitive impairment, that we want to make sure that we're still connecting them with those resources and services. And lastly, our agency does work pretty closely with law enforcement if we do have concerns for the driving of an individual. And so we want to make sure that that's something that we are looking at. There can be times when our agency is involved and we may have to look at it again 6 months from now to see what the progression has looked like for that individual as well. Because maybe there's just some initial concerns, but then things have escalated pretty quickly. And so then we may have to look at it. But again, we would be looking at working with those caregivers, family members, medical professionals to make sure that the resources are there. Our agency is not to restrict, revoke, or take that away. We want to make sure that we've got help that person age in place successfully and then with the best resources that they can.
Okay, I will jump on and finish this up. I think I'm the last one.
Sorry.
That's okay for mine. So again, my name is Jamie Troyer. I am with the trauma program at the University of Utah, and my job is injury prevention and outreach. And I am a nurse by trade. So we focus more looking obviously on medical, on injury prevention. So I wanted to introduce two things to you guys, and you can get more information from me at any time. So the Yellow Dot program is a grant-funded program through the Department of Public Safety and Highway Safety through their vulnerable road users group, especially our older adults. For me, the Yellow Dot program is for any driver on the road. So this is a folder that gets put in the glove box. And what they do is they fill out any medical information and emergency contact. So if they're ever in a crash, unconscious, unable questions, law enforcement or EMS knows if they see this sticker in the window, which is a yellow sticker you can see on the screen, they know to get in the glove box and see that this is all the information they need to know. If any of you guys are familiar with Vial of Life, this is very similar, but it's for your car and driving. Especially important, obviously, for our older adults, maybe those that we've talked about who shouldn't be driving but are still getting behind the wheel to know, do they have some sort of dementia, Alzheimer's, other medical issues that might be causing any issues with driving. But again, I have one in my car because I could just as easily be in a crash. And emergency contact is huge. People's wallets get lost, phones get lost and injured, or broken. So having emergency contact in there and something that's on paper We do have a lot of our older adults ask me if this is something that somebody could steal their identity with or find their address and break into their house for medications. And as far as I know, that has not been an issue and has not happened. And they don't have to put full information in there where somebody could find them. So just knowing that, again, this is an option. I go out and do presentations on the Yellow Dot program to senior centers, to older adult communities, anything like that, talking about that. And then I do specifically talk about some of the medical things that can happen, injuries that can happen. And on our website there, the Adult Driving Safety, you can find a lot of the resources that Brooke was talking about, as well as the Sugar House Clinic information is also on our website. You can look at the Yellow Dot, and then the website also comes in a printed form, in a book form that's very similar to the Hartford book that folks get. So, and just to throw that out there, that if they, anybody can take the AARP Safe Driving course, they get that Hartford book. It's not a driving assessment like Brooke does, but it gives you a lot of resources. And it also has a focus in there specifically on dementia and Alzheimer's and how to talk to your family member. Because my goal, again, is to help them be safe on the road and behind the wheel. And as everybody has talked about, is talking early, talking often about some of those things that could cause them to not be able to drive any longer. And then secondly, I also want you guys to know that when I talk to law enforcement and our emergency medical providers, I talk to them about this DOSI screening, which is a driver orientation screen for cognitive impairment. So thinking about if they pull somebody over or somebody gets in a crash and maybe they don't need to go to the hospital, but maybe law enforcement or EMS feels like there's something off that they should not get back behind the wheel. So they have this option to do this screening and then maybe call somebody. They can't stop them from getting back in the car, but it gives that screening that maybe they do need to fill out the driver's license referral. And so one thing that I've taught EMS and law enforcement is if they do this DOSI screening and it's positive, that they definitely should do that driver's license referral that law enforcement can do right from their tablet when they pull somebody over. So just to know that's that extra, help of maybe, like Brooke said, if they're not ready to give up that license yet, maybe it's this extra push of if they're found on the road of, hey, really, I'm not safe to be driving. And we know nobody wants to cause any issues. And again, my contact, you can barely see it on the bottom, but you can reach out to me anytime for more information about Yellow Dot, anything like that. So thank you for having me.
Great.